Welcome everyone to a special Tuesday edition of the VMICE Research Conference. And actually, as often happens at the end of the term, there's a whole bunch of people slated to present this week. So this is the first one, and we have another one tomorrow, and then the usual time on Thursday, and then another one on Friday. So this session is Sean Babcock's master's thesis defense, and his committee is right here. I won't go through the ultra-long rigmarole because everyone who's been here before knows the rub, but basically he will present the public, a few of us in the public can ask him questions, and then we'll leave him to his committee, and then he'll be excused from the committee, and they'll decide whether he successfully defended his thesis or not. So Sean is a student in the VCB track, or major as we call it now, in the program. He received his Bachelor of Science degree in Electrical Engineering from Portland State, and also attended a graduate program in Very Large-Scale Integration Design, also at Portland State. He has worked in the electronics and computer industry over 25 years, and his area of research focuses on machine learning and computer image analysis of a prostate cancer MRI data set. So we will hear about that.
Thanks, Bill, and thank you for coming. My thesis defense on computer-aided diagnosis of prostate cancer using multi-parametric MRI and evaluation of feature extraction and classification. First, I'd like to go through an introduction and background on prostate cancer and diagnosis methods. So prostate cancer prevalence in the United States. The NIH in 2018 projected that prostate cancer will be the third highest in the number of new cases behind lung cancer and breast cancer. And so as we can see, prostate cancer amounts to almost 10% of all the new cases projected in 2018. And it accounts for almost 5% of all cancer-related deaths. Prostate cancer, if diagnosed and treated early, does have a 5-year survival rate of 98%. And this is when the prostate cancer is localized to the prostate gland only and not metastasized to other parts of the body. So, current prostate cancer diagnosis methods. First, we start out with prostate cancer screening, which has two forms. A prostate-specific antigen blood test and a digital rectal exam. Given an elevated PSA or DRE abnormalities are found, the patient is then undergoes a transrectal ultrasound-guided biopsy. If this proves an inconclusive biopsy, then the patient is referred to a magnetic resonance imaging guided in-bore biopsy. It should be noted that all 78 patients in this data set have undergone this series, where their truss biopsies were inconclusive, and then they were referred to the magnetic resonance in-bore guided biopsy. So what is a magnetic resonance in-bore guided biopsy? First, human image analysis from a pathologist decides if a biopsy is one needed and determines the region of interest to guide that biopsy. This method has an improved accuracy over the truss biopsy method, and it also provides ground truth for computer image analysis, so studies such as mine. However, possibility of overbiopsy is due to human visual limitations. And these limitations are the human's ability to detect subtle pattern differences and intensity variations in an image. So what is multiparametric MRI? And I'll give an example of multiparametric MRI modalities used here at OHSU for prostate cancer diagnosis. And the first is an anatomical T2 weighted image. This type of image looks at the water content in specific tissues. So it gives a spatial resolution of different tissues and a spatial resolution of healthy tissue versus any malignant tissue. This method is then added with two functional MRI image types. The first is diffusion weighted image. And this type of image looks at water molecule diffusion through tissue and through cells. And from a diffusion weighted image, an apparent diffusion coefficient map is calculated. And the second type of functional MRI image used is dynamic contrast enhancement. And this is where a contrast is introduced to the patient intravenously, and it measures blood flow through various tissues and through healthy tissue and cancerous tissue. So, ADC maps calculated from the diffusion weighted image are the new game changer used by radiologists and in computer image analysis. So these have moved us a step forward using these apparent diffusion coefficient maps. Now, from literature studies in prostate cancer, multi-parametric computer image analysis use predominantly T2 weighted and ADC maps, or a combination of T2 weighted imaging, ADC maps, and DCE for their multi-parametric features. I've highlighted in red here the two modalities that I'm using in the data set, which are T2 weighted and ADC. Here at OHSU, we did take dynamic contrast images. However, the physician that provided this data set thought that the DCE images didn't lend any more information than was already present in the T2 weighted and ADC maps. And that's why we only have the two in this data set. So my project definition. The overall goal is to build an algorithm that best identifies malignant and benign patients with the potential of reducing overbiopsy and ultimately enabling in silico biopsy. So in silico biopsy would be something we could achieve one day where the imaging alone could tell us if the patient was malignant and benign, and the patient would not have to go through an invasive needle biopsy. A specific aim of this project is to evaluate the feasibility of machine learning methods based on feature extraction from the images and classification for differentiating benign and malignant prostate cancer tumors in multiparametric MRI. And so the materials and methods that I used in this study. First, the image data set used in this study. So I have processed images from 78 patients that were collected here at OHSU. And the table shows the breakdown between malignant and benign patients. So as you can see, we have 55 malignant patients with a total of 155 associated images. I have 23 benign patients with a total of 64 associated images, for a total of 78 patients with 219 images. One thing important to notice here is the unbalanced nature of the data set. I have a lot more malignant patients than I do benign patients. And the two right-hand columns show that I have images from both the peripheral zone and the transition zone of the prostate gland. So we have a robust data set to look at two different areas and two different, and the way they look differently to MRI images. To point out, regions of interest, or ROIs, have been identified by a radiologist for these images. MRI inboard guided biopsy was used to provide the ground truth for the malignant versus benign classes. Malignant patients. These patients have a Gleason score of greater than or equal to 6, and so this is a score of 6 through 10. And what this means is the pathologist, in assessing the cells, saw that the cells were high grade, aggressive, and fast growing, and thus likely to spread to other areas of the prostate gland. The benign patients in this data set have no Gleason score. So, although the cells look abnormal, they look closer to the healthy cells than do in the malignant. They're thought to be slow growing and non-aggressive. And once again, only images that look suspicious for cancer are included in the patient image data set. So in the center column, we can see that malignant patients have anywhere between 1 and 8 images per patient, and the benign have anywhere between 1 and 6 images per patient. Now, this is dependent on the ROI that was identified by the radiologist. So some regions of interest are smaller, some are larger, and so even though the patients have the same number of images taken, very few will show the region of interest. And so here, malignant and benign examples of the T2-weighted and the ADCmap images. T2-weighted on the top, ADCmap on the bottom. One, you can tell the difference in how these images look on the computer screen. The red arrows indicate where suspicious areas looked to the radiologist. And as you can tell, it's a little, at least for me, easier to see on the ADC maps where these regions would be versus the T2-weighted. And so here's the exact same images. The red outlines show what the radiologist actually outlined as a region of interest, and these outlined areas will be used to guide the biopsy area. Okay, so the algorithm flowchart that I used. As mentioned, I'm using T2-weighted images and ADCmap images in this data set. These are first run through the first step, which is image pre-processing. The image pre-processing step will give us T2-weighted and ADC extracted ROI areas. And it's from these extracted ROI areas we will run through a second step of texture feature extraction. And the texture feature extraction will yield texture feature vectors representing these regions of interest. They'll run through a third step, which is dimensionality reduction. And the purpose here is to reduce the larger texture feature vector to a reduced texture feature vector. Then we go into a fourth step using various classifiers to classify malignant and benign images. From the results of the classification, as you can see in the top right graph, a receiver operating characteristic curve is generated from the classification results, and an area under this curve is calculated. It's this area under the curve that will be used as the metric that will judge classification accuracy. So the first step, image pre-processing denoising. I've used 3 denoising methods. The first is a median kernel method, and this is simply a 3x3 pixel centered on the pixel of interest that is convolved across all pixels in the image and finds a median value around that. This is a very popular method in image analysis, as it tends to remove random noise with less blurring of the underlying image than do other linear smoothing filters. The second is a variational autoencoder, and the third is a convolutional autoencoder. I also use an autoencoder for dimensionality reduction, so at this point I'd like to take a few moments to explain autoencoder. As shown on the bottom here, the autoencoder is a neural network that's built up of 2 segments, the encoder section and the decoder section. And so essentially we're taking an input vector of values and we're encoding those to a smaller vector, which we call the latent layer. This latent layer is then decoded back to an output layer that matches the input layer features. And it's from this we can train this neural network to come up with a latent layer that best represents that input layer of features. So in image analysis use, these autoencoders have shown use in image compression down to a smaller layer, but they've also shown good use in image denoising, and that's why I've included several types here. In the variational autoencoder, the image is broken into one long vector of pixel intensity values that are run through the autoencoder. In the convolutional autoencoder, the 2D image is taken, convolved with several filters to perform the autoencoding function. So step 2, texture feature extraction. So the features in the study have been extracted from two-dimensional ROI images, as shown in the top picture. So from that ROI outlined, we produce a texture feature vector. I've used 5 methods. The first is gray level co-occurrence matrix. The second is gray level size zone matrix. And the third is a gray level run length matrix. All 3 of these methods will produce a matrix from the extracted features of the ROI, and then calculate second order statistics from that matrix to give us our texture feature vector. The fourth is a local binary pattern, where around each pixel a binary pattern is calculated, and this is more of a histogram-based method, counting up the different patterns that we've extracted. And the fifth is the multi-resolutional fractal dimension method. And what this entails is using wavelet decomposition of the image. And from the wavelet decomposition of the image, the fractal dimensions are calculated using what is called a box counting method. So, the extracted features for both the T2-weighted and ADC modalities. So here I'm showing the extraction feature methods and the number of features we get from them. So first, the co-occurrence matrix. It will give us 13 features per direction for a total of 52 features for all 4 rotational directions of the image. GLCM is also employs an averaging of the 4 directions to give us 13 features. The gray level size zone matrix produces 12 features in our vector. The gray level run length matrix will give 12 features per direction for a total of 48 features for the 4 rotational directions. And averaging is also applied here from the 4 directions to give a total of 12. The local binary pattern gives 36 rotationally invariant features. The fractal dimension method gives 4 features per direction for a total of 16, once again for the 4 directions, and also applies averaging to yield 4 features. So what we want to notice here is there's a total of 30 feature vectors that were extracted for each modality. It's from these 30 features for each modality that then are combined to produce the features for our multidimensionality features. Step 3, dimensionality reduction. And so the goal of dimensionality reduction is to find the best subset of features that best correlate to the benign and malignant classes in order to reduce classifier overfitting, which improves classification accuracy. And so here I've used 3 methods. First is minimum redundancy, maximum relevance. This has been shown to be used extensively in prostate cancer image analysis studies with great effect, and so I've included it here. The second is elastic net. This is popular in machine learning and pioneered by Trevor Hastie down at Stanford. It's also used in many prostate cancer analysis studies, and so I've used it here as well. And the third is the autoencoder. And so this autoencoder is fully connected neural network. It's commonly used in machine learning, not so much in prostate cancer image analysis. So here I wish to assess its usefulness in prostate cancer image analysis against the other two widely used methods. So step 4, classification. So here I've used 4 different classifiers. First is support vector machine. This has been shown, again, to be used extensively in prostate cancer image analysis studies. This does well at separating various data class distributions. The random forest, again, used extensively in prostate cancer image analysis. Random forests do well with noisy data sets, which they may very well have here. The third is logistic regression. Logistic regression is tied in with ElasticNet. So ElasticNet is the penalty term on the input variables that are then applied to the logistic regression classifier. And fourth is an ensemble of classifiers. So in looking at the results that I got from the individual classifiers, I showed a large variance in classification error. And that lends well to an ensemble of classifiers method. And step 5, now we must evaluate the models. I used a k-fold cross-validation method with a k equals 10. And so to illustrate that, we'll look at the table on the left. And so what this entails is breaking up the data set into 10 subsets or folds. And then one fold is held out for testing while the other folds are used for training. Now, if we remember back, the malignant and benign data set was quite unbalanced. So here I was able to separate the malignant portion of the data set into 10 subsets. But in order to balance each fold between malignant and benign images, I could only break up the benign images into 5 subsets. So here I had to reuse the benign 1 through benign 5 in the last 5 folds in order to balance these data sets out. Now, however, to avoid training bias, the fold whose benign data matches the selected test fold is left out of the training set. And as an example, if I hold out fold 1 for testing, I also have to hold out fold 6 and not use it for training. And the reason is, both of those folds contain the benign 1 subset. So if I train with the benign 1 subset and I test with it, I'm going to bias myself toward very good benign predictions because I've already trained with those. And so this essentially turns this into a 9-fold cross-validation, where I hold 1 for testing, 8 for training, and the other one's held out and not used. So as I mentioned before, the model evaluation metric for classification accuracy is the area under the curve. And so ROC curves are calculated for all 10 test folds that we go through. Here on the right, I've shown an example, and I've cut it down just to 3 ROC curves, just for clarity, so I don't mess this up. You can see each one has a different color for a different fold. And an AUC, so the area under these curves, is calculated for all of the, each ROC from the folds. And so the final evaluation metric is a mean of all 10 AUCs. And I've also represented those with a plus or minus 1 standard deviation in the following results. And so the models used in this study. So a model consists of a dimensionality reduction method and a classifier. And so you can see I've got MR and SVM, MR and random forest, autoencoder and SVM, autoencoder and random forest. So here we'll be able to tell, using the same classifiers with different dimensionality reduction methods, we can judge, does MR or autoencoder perform better or worse? We can get a judgment between those two in using the same classifiers. Number 5, ElasticNet, as I mentioned, it goes right along with logistic regression. And then a sixth ensemble of classifiers was used. And I took the 5 classifiers, individual classifiers I call them, and then take a majority vote from all the individual models to get the final classification. Okay, and now results. So first, the image denoising in step 1 shows the VAE underperforms. And so I've used a mean squared error, which is used to compare denoised image deviation from the original image. So the lower the number, the less deviation from the denoise to the original image. And this table shows an average MSE for all of the T2-weighted images and all of the ADC images I had available. I've highlighted in red that the VAE vastly underperforms the kernel or the CAE method. So because the VAE shows much greater differences from the original image than the kernel or CAE methods, it was not used in assessing model performance using denoise images. So I left that out. And here's kind of a visual example of what we're talking about, where the VAE removes image pattern information. So besides removing noise, as we wanted, it's removing pattern information that I need to extract from these features to better predict the classification. And so here I've shown T2-weighted denoised images and ADC images against the original image. And so what we can see, I highlighted in red. If you look at the original, the kernel, or the CAE, the dark and light pattern information is preserved with the kernel and the CAE methods. However, it is not preserved in the VAE images. This table shows just the MSE for these particular regions of interest examples. And again, vastly underperforms what we get for kernel or CAE. So here's one key result from the study. Multiparametric images outperform individual T2-weighted and ADC images. So I've listed for the 5 models on the left-hand side. I've listed the best T2-weighted AUC and the best ADC AUC for these models. And I've also listed the best parametric AUC for these models. I've highlighted these in bold because for every model, the T2-weighted image or the multiparametric images outperform T2-weighted or AUC. Now we can get some information from this table. The first is the MR is preferred over the autoencoder. So if you look at the first 4 rows using the same classifiers, that the autoencoder underperforms what the MR produces. Also in general, neither the T2-weighted nor ADC stand out for classification performance. That may be with the exception of the second row, MR and random forest, where ADC does seem to perform better. But in general, ADC and T2-weighted are not outperforming each other. And I'll also note, from looking at all the numbers, the multi-parametric features account for at least the top 2 AUC scores for all models. Here I've just shown the top, but at least the top 2 for all models. So the conclusion I draw here is I recommend using multi-parametric features over the individual T2-weighted or ADC features. Now we can find a recommended multiparametric feature and model. I've highlighted this with the red arrow over on the left-hand side. So what we can see is based on our AUC metric that the MR and random forest model performs best over the other 5 models. And the best feature is a T2-weighted LBP bin size 1 combined with an ADC LBP, a bin size 3. I've also here shown various other metrics, such as sensitivity, which is the ability to correctly predict the malignant class, The specificity, the ability to correctly predict the benign class, and positive and negative prediction values, which basically say, if this test says you're malignant, for example, then that's the probability that you truly are malignant and haven't been misclassified. One other thing we can notice is the makeup of the features. As we saw with our best feature, these were a combination of T2 weighted and ADC with different feature types. If you look at MR, and SVM, this was ADC and LBP, but they were both in size 1. And here is 3 features that are all multi-parametric. So these have ADC and LBP, ADC and LBP, ADC and LBP, and they were the best. So there's a myriad of different ways of the multi-parametric features being combined that give us the best. So what can we get from this? Based on the AUC score, the MR and random forest model is my recommended image level model. And if we notice that LBP is totally or partially involved in the 5 models' top AUC scores, and so as shown in column 2. So thus, my recommendation for multi-parametric feature extraction method is LBP. So let's look at the multi-parametric feature model comparisons without having to look at all these numbers. I think this graph is a little better to show all the various models. Note that if you had an ideal best model, that all the bars for that model would be up at 1 or close to 1. And so as we see, MR in the random forest over here on AUC is the best AUC. However, for sensitivity, it is the 3rd best, even though it has the highest AUC. And it does show a trade-off between sensitivity and specificity. Similar for the dark blue MR, and SVM. It's the 2nd best AUC score, but it has the best sensitivity score and also shows that trade-off between sensitivity and specificity. So we're predicting better on malignant at the sake of predicting benign. ElasticNet somewhat shows the opposite, where it is the lowest malignant predictor in specificity, in sensitivity, but it's the best in specificity. So what do we take away from this? Each model shows different strengths. And that's why these lend themselves to an ensemble of classifiers, so we can exploit the best strengths, or try to exploit the best strengths of all models. So here we show ensemble of classifiers is the best model. So the same graph, but I've added ensemble in the black bars. And as you can see on the AUC score, it has the best score. And in fact, shown in the red arrows, that the ensemble model performs the best or toward the top for 4 of the 5 performance metrics, with specificity being the one that's left out. So what we can see here is that the ensemble had an AUC of 0.773, which showed improvement over the individual model, MR and random forest, with an AUC of 0.754. So the overall conclusion is that the ensemble is the best image classification model. So let's go back to the original and denoised image model results. Here I've shown along the x-axis the different model types and the AUC. With the original image in blue, the kernel denoised image in red, and the CAE denoised image in green. And here we show the AUC plus or minus its standard deviation. And so what we see here is based on the majority, which is 3 of the 5 highest AUC scores, the original image ROIs were selected for model evaluation. We didn't need the denoised images. So all of the results that I've shown previously were on the original images, not denoised images. I say, however, I recommend that if dataset denoising is performed, if one wants to compare their denoised image versus their original images, that you should use the CAE denoising method, as it performed better than the kernel method. Okay, we found the image level model. We found our best image level model. So now, determining a patient diagnosis model. So let's move this into the clinic. What is a useful diagnostic decision support model in a clinical setting? And so what we have to do is apply the image level model to the patient level. So we're going from image classification to patient diagnosis. And so I've set the goal of the best model as the model with 0 or the lowest number of misdiagnosed malignant patients. And I'll reiterate here that reducing misdiagnosed malignant patients is paramount. I would rather send a patient in that's benign for over-biopsy than let a patient walk out the door that is malignant with an aggressive cancer that goes untreated. And so I've set a patient-level model assessment criteria, and that is if one or more images in the patient's data set is classified as malignant, then that patient is classified or diagnosed as malignant. And so here we'll see patient diagnosed results using adjusted malignant thresholds. So if we look at the top here, the malignant threshold probabilities, I've used 0.5, which is the standard criteria. If you're 0.5 or above, you're malignant. 0.5 below, you're benign. And I've also adjusted the threshold to say that if you're above 0.4, you're malignant, and below that, benign. So this just builds a little insurance in, if you will, to say, well, if you're close to being malignant, we're going to count you as malignant. So in the table, I basically show in the black the 0.5 malignant threshold probabilities, in the green the 0.4 malignant probabilities. As we see, two models now appear with the shifted 0.4, and that's MR-MR in SVM and autoencoder in SVM. They both have 0 malignant patients, misdiagnosed malignant patients, which meets our goal. And as you see, at 0.5, no model had a 0. So just a slight shift got us 2 models. Also notice that the Ensemble model, as we pointed out, was our best image level model, but even with shifted, it still has 1 misdiagnosed malignant patient. So these don't, the best image level model does not necessarily correlate to the best patient diagnosis model using the criteria that I set. So although malignant, or MR-MR and SVM, and autoencoder and SVM have 0 misdiagnosed patients, as shown in the red, the SVM has a better benign patient diagnosis. So as we can see, here's the truly benign diagnosed patients is 8, and the truly benign diagnosed patients is 4. So in the MR and SVM, we traded 1 more malignant accuracy for 1 less benign accuracy. But we're still, out of the 23 patients, getting 8 properly diagnosed benigns. So my conclusion is, based on that MR-MR and SVM is the best patient-level diagnosis model that we would recommend in the clinic. So some discussions. We'll discuss a little bit of the previous results. First, conclusions. So basically, I've demonstrated an algorithm to enable computer image analysis of benign and malignant cancer patients that is shown to work fairly well. It demonstrated that multi-parametric MRI is better classification accuracy than T2-weighted or ADC alone. And I've introduced, to the best of my knowledge, the concept of ensemble of classifiers to multiparametric prostate cancer image analysis. And that ensemble method was shown to be better than any individual model at the image level. And so for this particular data set that I have, particular small data set that I have here from OHSU, I have found that the optimum patient level clinical diagnosis support model is MR-MR using an SVM classifier with a polynomial kernel. And the optimum feature extraction method is LBP using a bin size of 1. So I'd like to talk a little intra-tumor heterogeneity and how that relates to image diversity. This is also known as genetic heterogeneity, which is defined as an uneven stratification of cell subgroups in a tumor. And so this is based on that cancerous cells in a tumor do not all grow at the same rate. And so what I've done is taken an ROI image from an ADCmap and converted it to color, just so it's easier to see. And 6 image slices would be used to indicate the biopsy area, to find that ROI. So if you could think of these images showed the color is the region of interest that was suspicious, and the white area around it is healthy prostate tissue. So as you can see, image 1, image 3, image 6, they don't cut through very much, if any, malignant tissue, whereas image 2, 4, and 5 do cut through malignant tissue. So now we have images in a single ROI that show benign and malignant tendencies. So heterogeneity is a cause of malignant patient image misclassification. That would be a limitation to the study. And here's why. In this study, all patient image slices are labeled based on biopsy results. The images are not correlated to the biopsy area. The images just find the ROI. The biopsy tells if the patient is malignant or benign. So we could have, as in image A, a likely benign image, but it's mislabeled as malignant because it is in this patient's data stack. Image B shows a low malignant area, but most of it looking benign, and this may be classified as benign. Again, it's labeled as malignant, but it may be classified as benign. And then C, a highly malignant area classified properly as benign. So you can say, here's why I came up with 1 or more images in a patient's set. If it was malignant, the patient would be malignant, because this would tell us the patient was truly malignant, and that's backed up by the biopsy. What does this mean? Well, we're going to get confusion. These images labeled as malignant, but they look like benign, are going to cause noise in our data set. And that's going to confuse our classifier, because you're going to have similar extracted features, but 2 different labels. I've also looked at correlations. So the first correlation I looked at was, do misclassified images have any correlation in the image stack for a patient, meaning at a specific area of the region of interest in the prostate gland? And the answer is no. They have no correlation. I looked at the ROI size. Did ROI size have any matter? And there's no correlation to ROI size to misclassified malignant or benign images. And the third thing I looked at was, do they, if you remember, we have transitional zone and peripheral zone images, do they correlate to either of these 2 zones? Because different MRIs pick up different things in different zones. And the answer is no, there was no correlation between misclassified. So as that was a possible limitation of the study, other study limitations. So we have a small training set for classifiers. Does anyone who's ever done machine learning or even looked at data, more data is better, and that gives you a more robust data set. And a larger data set also will negate the effect of any of these outliers that we may see. Second, we saw an unbalanced data set between malignant and benign patient samples. It would be nice to have a benign data set that was more robust. I duplicated the same benign patients, which didn't give me any better variation in the types of benign patients. And ideally, 3D images would be preferred to the 2D images used in this study, because 3D images give more information between the 2D slices. These slices were based on 3mm slices, so we've lost on 2D images any information in between these. So future directions. Obtain a larger patient data set. While I was working on this study with 78 patients. Dr. Coakley has told me that we have over 200 patients now for the data set. So if we redid this study, we will improve. And once again, 3D images over 2D images. If we could collect a large enough data set of 3D images, then we could improve this study. So at this point, I will wrap up with acknowledgements. First, my thesis committee, Zhubo Song, my thesis advisor, Ted Ladaris, chairman of the committee, and Guillaume Thibault, also on the committee. And key contributors, Dr. Fergus Coakley, he provided the data for us for this image. And also Arshana Makharidi, who was instrumental in working with the radiologist to basically correlate this data set, both the images and the ROIs, and getting them into a format where I could easily use these and start working through my algorithm. And that's it.
Nice study, very, very interesting. So it seems that there would be two sources of error, basically. So one is your machine learning algorithm, misclassifies things. It seems that another possible source of error would be that the image findings don't perfectly correspond to the biopsy findings. And I'm trying to formulate this into a question, but I guess how much do we know about that, just in terms of how good? Because it just may be that if there's not a absolutely perfect correspondence between what's in the image and what's seen under the microscope, how does that impact your results?
It would definitely, I'll preface it by, I wrote a paper for one of my classes on radiogenomics, which was the mating or mapping of imaging to genomic studies. And that required that you knew what part of the biopsy was linked with what image. Then you could go look, sequence, find out overexpression, underexpression, and tie that into an image with the hope that the image would tell you what the genetics, if this was over or underexpressed. And the key on that, it's a new field. And basically all the papers I read said, well, if we can do this. But to date, I don't think that I've ever read that anyone could accurately look at that. Certainly if you could find that the biopsy from that slide and match it to that image, we could get rid of one of the limitations of the heterogeneity. Mm-hmm. I really think so.
Let me maybe ask one more question. I like the clinical correlation that you did, because I kind of have a clinical perspective on things. This notion of minimizing missing malignant diagnoses, I think, is a good one. In essence, that becomes like a screening test. We commonly do screening tests for cancer. And when you do a screening test, you want something that's 100%, well, as close to 100% sensitive as you can get, because there'll always be some kind of follow-up. What you don't want to have happen is to miss something in the screening, because then that patient will think that they're they don't have the disease, and you'll never see them back. So wouldn't it be that the models with the highest sensitivity would lead to the lowest rate of missing a malignant diagnosis? Mm-hmm.
Yeah, and yeah, if I went back through, I could go back through. If you actually looked and saw that for the individual model, or even the Ensemble model, who had better AUC scores than did the SVM plus MRMR, which turned out to be the best patient diagnosis model. if you look at those numbers on that chart, that the SVM, the one we came up with for patient level, did have the highest, 0.88 sensitivity. The rest went to 0.84 for the Ensemble and 0.8 for the MR and Random Forest. So that did tie right into it. Right into it.
Great. Any other?
Thanks, John. So I have a question about the size of the ROI, the correlation. I didn't quite catch it. What that correlation is? You were saying it's not correlated. When Fergus just emailed us a couple of days ago saying we should consider size as an informative feature, which is not considered here because over here we're all using texture features. So is size related?
To the misclassification?
Yeah.
No, it's not. So I went through, and I do have the areas, and I worried about some of the extraction methods, because I go through and I look and I say, well, okay, like LBP, for instance, right? I'm making a histogram of those, and if I have a small size, obviously my histogram is going to be very small, even though it's malignant or benign, compared to another one that has a larger size and has more of that particular pattern. And so I worried about that. I said, okay, let me look at size, because LBP seems to be my best thing. Could I make it better by, looking at the size? And that was not the case. So when I went through so I made a spreadsheet of, here's the AUCs, here's all the metrics, here's the sizes, here's the zone they're in, here's the location in the image stack. Now that's given that the image stack was preserved throughout the process. And so that number one was toward maybe the base of the prostate gland and down the line. And I didn't see, that was one of the first things I thought of a long time ago, is I said, well, what about the size? Because some of the sizes of these, you can think of it maybe as the region of interest like an egg, and if you just chop the top of that egg off, it's going to be a small size. And in the middle, it's going to be a much larger size. And I said, is that throwing things off? And both malignant and benign misclassifications didn't show any correlation to the misclassified images. And I thought that was going to be the low-hanging fruit, and I was going to say, sure, I'll just leave anything under, and Arshan and I talked about this. We were thinking, because I spoke about that with her, I said, well, maybe we can just say, okay, we can leave out in a patient's image set. So we're not leaving any patients out, but in their set, we could just leave out a small ROI under a certain area. But we found no correlation, which was interesting. Excellent. Thank you. I need water.